Okay, I think we'll get going. I'm Danny Weiss. I'm a neonatologist and director of the teenie program at Sunnybrook Health Sciences Center in Toronto, joined by the co-chair of the Education Committee of the NHRC, Dr. Danielle Rios from Iowa. And welcome everyone. Thank you for joining us for, I think it's the eighth lecture in our Foundations curriculum. And ahead of that, just an acknowledgement that the neonatal hemodynamics and the TNE NPE Foundations curriculum is supported by an unrestricted educational grant from Mallinckrodt Pharmaceuticals. And the topic today is post-PDA closure, and I'm very, very pleased and excited to introduce our speaker, Ms. Dr. Adrianne Bischoff. She's a clinical assistant professor at Iowa Children's Hospital. And her work over the last couple of years has focused in this really interesting domain that I think encompasses a lot of key principles in neonatal hemodynamics. And Adrianne, I'm happy to hand it over to you.
Thank you, Dr. Weiss. Let me try to share my screen here. Can you see the correct screen with the presentation?
Yes, we can.
Okay, great. Just move this. All right, so I've been assigned to give this topic, which probably a good amount of people in this audience have already seen slightly different versions of it, but I tried to make it a bit more like a lecture for the trainees and hopefully clarify some of the key concepts related to the physiology of post-closure and a little bit of what we know from the literature. If there's any pressing questions in the middle, I will have periods where I will stop and try to call people out to ask some questions that I sent up front. But if there's anything that is very unclear, please just interrupt me and we can try to clarify that up front. Right. So we know that there's been a significant decrease in the number of surgical PDA ligation over the years. This is a graph from several neonatal databases, and you can see that from the early 2000s to the mid 2000s, there's been a trend towards less surgical closures. And some of the reasons for this include not only a contemporary shift towards a more conservative approach to the PDA management, as well as the inherent surgical risks, which I listed below, but also derive from several studies that reported an association between PDA ligation and adverse neonatal and neurodevelopmental outcomes. So the first question that I set for the group, and I'm not going to start calling people out quite yet, is what are some of the caveats in these studies that pertain neurodevelopmental outcomes in post-PDA closure? So there's been very few randomized controlled trials of PDA ligation versus conservative or medical approach. And the ones that do exist are actually quite old, from a pre-surfactant era. And they are in preterm infants that were more mature than the majority of infants who undergo definitive closure in contemporary practice. The other big problem in these studies have to do, first of all, with a limited estimation of PDA significance. And a lot of these old studies actually used only clinical features to define PDA significance. And while we know that neonatology is a field that has evolved tremendously over the past 30 years, specifically as it pertains to improvements in respiratory care, the use of different modalities of medical therapy, what we know from today is that surgery actually is reserved for patients whose shunts are prolonged, who are pharmacotherapy resistant, and who happen to be in preterm infants who also have respiratory failure, either from a combination of lung immaturity, but also inflammation that comes not only from exposure to a shunt, but also infection and ventilator-associated lung injury. Since we can't really rely on these outdated RCTs that don't really reflect any of the contemporary clinical practice, what we do have is data from a lot of observational studies where the conclusions were overall that PDA ligation was associated with less mortality, but at the expense of increased neonatal morbidities, including BPD, ROP, and neurodevelopmental impairment. And the two main considerations when we're looking at all of these studies relate specifically to residual bias of confounding by indication and also confounding by contraindication. So what do I mean by that? One of the first important caveats is that the infants who end up being referred for PDA ligation tend to be more ill at baseline, and that the other postnatal morbidities and parameters of physiological instability, they also predict neonatal morbidities and neurodevelopmental impairment. So for example, the intensity of duration of mechanical ventilation is not only a criteria in many centers to pursue with surgical ligation of a duct, but it's also an independent predictor of other morbidities. So it makes sense that if you do all of these studies and you don't adjust for postnatal pre-ligation factors, the infants who end up going for PDA ligation are sicker at baseline, and perhaps the worst outcomes that they have are not directly related to the ligation itself, but rather to the confounding fact that the ones who qualify for ligation are also sicker babies who are more likely to develop these morbidities anyways. But how do we explain the decrease in mortality then? And that can be mostly related to the fact that ligation is an event that tends to happen later in the NICU course when medical therapy has already failed. And therefore, some of the sickest babies may have already died before even becoming eligible for a ligation. And the ones who end up being ligated are more likely to have already survived a critical period of high early neonatal mortality. This is a study by Dr. Weiss itself, who is an excellent example of these concepts. I should have sent this one as well as the other articles, and I recommend for all of you to read it. But basically, the group in Toronto looked at 754 extremely preterm infants to compare the outcomes of medical PDA management against surgical ligation, while trying to minimize the effect of these residual biases due to confounding by indication. So first of all, I would like to draw your attention to this graph, where you can see that the infants who went for surgical ligation, who are in orange, they had higher ventilation requirements. So this graph is plotted. There's someone who needs to be muted. All right. So the graph is being plotted here for mean airway pressure according to postnatal age prior to ligation. And then you can see that the ones who went for ligation had already higher ventilator requirements even before heading for ligation. So if you say that these babies end up having more respiratory support later on, well, that's not really surprising because they already needed more even before they went for ligation. But more interestingly is that when the multivariable logistic regression was done, adjusting only for antenatal and perinatal factors, like most of the other observational studies, ligation was indeed associated with an increased risk for BPD, ROP, and neurodevelopmental impairment. But when they included an adjustment for postnatal pre-ligation variables, which is the last part of the table, the ligation then was no longer associated with adverse outcomes. Going a little bit beyond the scope of surgical ligation, as you know, and as you might have seen me talk about this before, there's a trend in many centers towards performing less invasive definitive closure through the percutaneous or transcatheter approach. What you see on the graph on the left is the center of Memphis, which is one of the centers here in the US that has done the most amount of these tiny babies. And you can see that percutaneous closure is increasing exponentially over the last couple of years and has even superseded what was done before in terms of surgical closure. And our group recently explored this trend in a meta-analysis as well, looking at infants less than 1.5 kilos. And found that 96% of these procedures, what is published in the literature, is that they are successful. And the graph that I put there shows that the estimated probability of failure decreases according to the age at the time of the procedure. One of the most interesting aspects that we found when we looked at all of these studies of percutaneous closure is that there's been an increase in the probability of technical success over time, going from less than 90% in the mid-2000s up to 98% in the most recent years. And what that has been accompanied is with a trend towards the procedure being performed in smaller patients, which probably reflects the learning curve and the fact that the people who do this procedure are feeling more confident, more comfortable, and have done more of these and know how to do it better in the smaller babies who tend to be more technically challenging. In terms of adverse events, I did put the surgical ligation risk adverse events on that first slide. These are adverse events related to percutaneous PDA closure. You can see that some of the major ones that can happen include death, cardiac tamponade, a repeat for cath or for surgery, or if there's any significant obstruction into any of the adjacent structures. While for minor adverse events, the things that we have seen the most in our experience and based on what we've read on the literature is transient tricuspid regurgitation, mild left pulmonary artery stenosis, and sometimes residual shunting. So moving away a little bit on the conversation from outcomes, how do we decide who to close and when to close? And I think the scope of this lecture is not really in discussing the merits and the outcomes of closing the duct, because you know that's probably one of the areas of biggest debate in neonatology. But as a general rule, patients who go for definitive closure either have a failure or a contraindication for further medical therapy. Most typically, these are babies who present with some sort of respiratory compromise, and they can have or not clinical concerns with systemic underperfusion. And hopefully in the centers that you guys are all training, there's an important value in looking at comprehensive echocardiographic evaluation of shunt significance as well. And obviously, importantly, before we send any of these vulnerable patients for invasive and definitive procedures, making sure that they are not septic and that the shunt can't be modulated with other strategies. Now I wanted to move on a little bit towards the physiology aspect and what happens when the PDA is suddenly closed. So as you all know, in the presence of significant left to right shunt, there is pulmonary overcirculation with high pulmonary blood flow and an increased QPQS with increased left heart volume loading. What that means for the LV in this situation is that the LV is being exposed to a relatively low afterload because the PDA is connected to a low resistance circuit, which constitutes the pulmonary vasculature. So the first two questions I have for the trainees, I'm not going to call anyone specifically, I will let the volunteers go, is number one, what are the changes in loading conditions that happen after definitive PDA closure? And number two, how do these influence heart function and stroke volume? Would anyone like to start?
So after the PDA closure, there will be an increase in the afterload, and there will also be a decrease in preload. And then how does this influence the heart function and the stroke volume? So all of this will cause, so the preterm myocardium is already stiff. So one of the things is that it is more difficult to adapt to change. So that could lead to diastolic dysfunction. And then the increase in with the increase in the afterload and decrease in the preload, you can also have systolic, systolic dysfunction. And with all of this, there will be a decrease in the LVO.
Perfect. Thank you, Steph. So yes, that is correct. We'll go through all of these in detail for the other people who may not have caught all of it. So once the PDA, so here's the same graph. Once the PDA, there you go, there's a Piccolo device, suddenly closes. There are significant changes in loading condition. On one side, there's a sudden decrease in the left heart preload because of the interruption of the shunt and of that second circulation through the pulmonary vasculature. But like you said, there's a significant increase in afterload because now there is no longer the low resistance circuit and the LV is exposed exclusively to the systemic vascular resistance. And the combination of these two loading changes is what leads to a lower left ventricular output. So there's been several studies on the mechanics of the LV following surgical PDA closure, showing that while the systemic vascular resistance goes up, there is an impairment in LV systolic performance, which you are seeing here on the graph on the bottom, as a decrease in LV longitudinal strain. And what you see here on this table is data from our group here at Iowa, and this is after cath closure, which also shows that there are significant changes in left heart volume loading measurements, as well as LV systolic and diastolic function within the first hour. So the first concept is that the changes that relate to PDA closure are primarily affecting the LV and not the RV, as some people might have thought in the past. If there is absence of pulmonary hypertension or other physiology, if you ligated the duct for the right reasons. So here is an example of a preterm infant. This is an apical 4-chamber view. You can see on the left that is pre-closure. It's a very dilated left heart that has a PDA shunt. And on the right side, you can see the scan of the same baby 1 hour after the procedure. And you can see that there's a lot less volume loading. And in this case, it's quite obvious that there is also reduced LV systolic function. The way that these physiological changes will manifest in the baby, first of all, is with an increase in the diastolic blood pressure. And that reflects the loss of the systemic steal from the PDA, with also a concomitant increase in both the systolic and the mean blood pressure. And what you can see on the graph on the right is data from the patients, again, from our cohort that go through percutaneous closure, where you can see that the diastolic blood pressure rises immediately after cath and continues to rise over the next 24 hours. In the lungs, the cessation of the left to right shunt is accompanied by an immediate improvement in lung compliance, which you can clearly see both in these chest radiographs before and after closure, but also based on ventilatory parameters. As you can see on this, I think this is one of the very few studies that looks at respiratory parameters in more detail, but you can see that the compliance improves quite substantially as well. So the next part of this is knowing that these are the physiological changes and this is the normal parameter. There is a disease that we call post-ligation cardiac syndrome, which is what we're going to talk about a little bit more now. So question for the trainees is, number one, what are the clinical components of post-ligation cardiac syndrome? And number two, what is the most likely underlying physiology that governs the clinical presentation phenotypes? Any volunteers?
I can go for that.
I'll answer if you want. Oh, sorry.
Sorry. Shall I go? We can split. I will answer the first question, you answer the second one, maybe?
Yes, why not?
Okay. So the components of the post-ligation cardiac syndrome is systolic hypotension and was like below the 3rd percentile, appropriate for age. And also it's kind of like also accompanying also with hypoventilation and like failure of ventilation and failure of oxygenation. And this is can be like, you know, a mix, so can be isolated. And I think that's the second question, right? So
okay, perfect.
So it's hypotension, hypoxemia, and hypoventilation.
Okay.
Thanks, Simon. So yeah, to kind of break that down into my understanding of the physiology anyway is, so it's largely affected by that increase in the afterload because of the increase in the vascular resistance systemically. And so that's something which occurs generally a little bit later. So over the kind of 6 to 12 hour period post duct closure, as the increasing effect of the afterload causes increasing sort of strain against which the heart's trying to pump. And so as the failing left ventricle is with its sort of systolic dysfunction is getting worse and worse, then that has a knock-on effect into the hypotension and then poor perfusion. And so that can then lead to the requirements of sort of inotropic therapy, etc. And then from the point of view of the effect on ventilation and oxygenation is from the fact that there's then back pressure. So the heart's trying to pump against an increased afterload. You've got left atrial dilatation. And then from that, it basically in a cascade back towards the lungs. So you then have increased pulmonary venous return, and you have increased pulmonary blood flow, which causes edema. That also can cause hypoxia, and with that as well can then cause problems within the vasculature in the lungs themselves, increased or decreased compliance. So then that would have an effect on hypoxia and ventilation.
Very good. Looks like you guys read the materials. So let's consolidate some of these concepts with my next few slides. So yes, now these days, because we're doing a lot more cath closures instead of ligations itself and surgery, we here at Iowa have adapted a little bit. Instead of calling this PLCS, we're just calling it post-closure cardiorespiratory instability, because it encompasses both surgical and cath closure. So what was traditionally called PLCS is a disease that is characterized, like Eamon said, by LV failure due to a high afterload state. And the full spectrum of the condition includes two components, one of them being cardiovascular instability, which is characterized, as you said, by systolic hypotension predominantly, with or without the need for inotropic support. And the second part of the disease is respiratory instability, which can either be impaired ventilation and or oxygenation. So talking a little bit of what are the mechanisms that explain these physiological principles. First of all, we did say that there were changes in both preload and afterload. So looking first at preload and remembering the Frank-Starling law, we know that the majority of the infants fall into the flat part of the curve, where they go from a volume loaded left heart to a condition of normal loading. However, if you had a baby who had a relative hypovolemia prior to PDA closure, whether they were significantly fluid restricted or whether they were on a lot of diuretics, then in those babies, the change in preload could cause an immediate decompensation after PDA closure, which is not what we typically see in the majority of the babies, since the use of excessive diuretics or very restricted fluid intake is not common practice in the majority of the units these days. But this is why it depends on where you are into the Frank-Starling curve. And for our babies here that we send to the cath lab, we try to keep them at a normal total fluid intake prior, and we avoid excessive diuretics prior to closure. On the other hand, the effect of afterload on heart function, just like you said, depends on sustained exposure, and that leads to a low cardiac output state, particularly in infants that have more vulnerable and immature myocardiums, which explains why the clinical manifestations that we see as part of the PLCS spectrum happen within 6 to 12 hours after PDA closure. So for those who do end up developing post-closure cardiovascular instability, the typical course is that after an initial period of stability, where you have those higher blood pressures in comparison to the baseline, there's a progressive decline in the systolic blood pressure. And what is important to recognize is, if you pay attention to this graph, is that the mean blood pressure remains relatively stable during a certain period of time. And that's because the diastolic, which encompasses 2/3 of the calculation of the mean blood pressure, is still normal or high. And that's why we pay particularly a lot of importance in all of the components of the arterial pressure, because if this window goes unrecognized in a patient who is likely to develop left ventricular failure, the disease progression then is characterized by a subsequent decrease in all of the components of systolic, diastolic, and mean blood pressure. Now look how this graph is different from the previous one. So here I'm showing a case where the baby develops early hypotension in the first 1 to 2 hours after closure, and that hypotension is predominantly diastolic. So it's important to note that neither early hypotension nor diastolic hypotension are part of the spectrum of this disease. And if this is the primary pattern that you're seeing in a patient, then you need to start thinking of other reasons for the hypotension that are not because of LV failure. And some of these can include preload problems, like those babies that we talked about that fell not on the flat part of the Frank-Starling curve. Lung hyperexpansion is another one that is sometimes not recognized when the baby returns from the procedure because the compliance improved a lot. And if you fail to wean the ventilatory support, then they can end up hyperinflated and compressing the heart and causing hypotension because of that. Adrenal insufficiency in places where steroids are not routinely used. Drug interactions with other vasodilator medications. And of course, we're talking about PLCS both for surgical and for percutaneous, but if there's any surgical complications like pneumo or hemothorax, then those would be accompanied by an early hypotension or a different type of pattern that is not that systolic drop after 6 to 12 hours. While we see that cardiovascular instability was very much described in the typical PLCS after surgical ligation, what we have noticed more often, particularly in our percutaneous PDA closure patients, is the respiratory aspect of the instability. And the proposed mechanism, Steph kind of alluded to this when she was answering her question in the beginning, but it relates to diastolic impairment, where if there's a problem with the LV relaxing or with the compliance of the LV, then the LV and the left atrial and diastolic pressure will increase. And then there will be, like both of you said, secondary pulmonary venous hypertension and then pulmonary edema, which can then lead to hypoxia and impaired ventilation. So here's an example of one of the patients from our cohort here of percutaneous PDA closure. You can see that before the procedure, the baby was on conventional mechanical ventilation with 35% of oxygen. The lungs look very hazy, very congested. There's some cardiomegaly. Immediately after PDA closure, you can see that there is a substantial improvement in the compliance. The lung fields are much clearer. But what happened is that over the next 12 hours, the patient develops progressive pulmonary edema, and there's both ventilation and oxygenation failure. And this baby had to be escalated from conventional to high frequency ventilation because of inability to clear their carbon dioxide. So progressive pulmonary edema with oxygenation and ventilation failure. So the next question I have for the trainees is, what do you guys know in terms of clinical and echocardiographic characteristics that are associated with a higher risk for post-closure cardiorespiratory instability? New volunteers, please.
Hey, Adrianne, this is George.
Hi, George.
Hi. So with regard to clinical, maybe as you said, the fall in the systolic blood pressure at around 6 to 12 hours of life. And probably the echocardiographic one will be a decrease in the left ventricular output to less than 200 ml per kg per minute will be an echocardiographic marker of an impending cardiorespiratory instability.
I will push you back a little bit on your first part of the answer with the clinical predictors. If you do have a low systolic blood pressure, then that's already kind of a clinical sign that you are developing, right? PLCS. I'm thinking more of what is there preemptively before the procedure, which babies do you think would be at higher risk for developing this condition?
So those babies who are, for which we do the procedure quite early, babies who are less than 1 kg, babies who are less than 28 days of postnatal age, those who have failed, means failed the ACTH stimulation test probably.
Okay.
Yeah.
Great. Did anyone think of the shunt significance or worse shunts being babies who are at higher or lower risk?
Yeah, so babies who probably have a higher pulmonary pressure are unlikely to develop this PLCS probably if the pre-procedure pulmonary pressures were high. They may be more in more chronic PDA. But if the shunt volume, if it's a high shunt volume, then the chance of PLCS is higher.
So yes and no. So the shunt volume was never found to be a significant predictor for developing PLCS. But I totally agree with what you said. For the babies who have more chronic shunts and who end up having some remodeling of their pulmonary vasculature and secondary increase in pulmonary pressures, you can think that those babies are already exposed to a higher afterload at baseline. Even though the PDA is still open and connected to that low resistance circuit, that low resistance circuit is not as low resistance circuit anymore. And therefore the change in afterload won't be as dramatic and won't be as significant. And therefore the baby's kind of protected from developing PLCS. Thank you, George. So here we go. Some of the baseline risks for developing these manifestations. What we know from the old surgical studies is that primarily the two main things are a lower weight at the time of the procedure, as well as the postnatal age. Oh, it looks like I have another question before I move forward. What are some of the caveats in the studies that report a low risk of PLCS after percutaneous PDA closure? Does anyone know that one? That one might be a bit hard if you're not fully aware of the most contemporary literature of these babies. Any volunteers? Steph, you can go. You've heard us talking about this before.
So I think one of the things was the, I think with the cardiac ligation, the inflammation cascade is higher. So that can be a reason why, and like in the babies that go under calf closure, compared to those, the inflammation cascade is lower. So that can be one of the reasons why the babies that go to closure are in lower risk.
Okay, we're going to expand a little bit more on that. Do I have another person? Eamon, do you want to say something? I see a hand.
Yeah, so I think also in the device closure, there is no thoracotomy, so there is no opening of the lungs and there is no lung collapse. And this is probably also protective and lowering the risk for the device closure.
Yep. Okay. Yeah, those two are good ones. There's a little bit more than that, and we'll talk about it on the next few slides. So to answer this question, besides what you guys already talked about, I will put this graph, which is very interesting because you can see that the risk of PLCS, and this was done with classic PLCS with the probability of inotropes, but the risk of PLCS in surgically ligation patients goes from as high as 50 to 60% when it's done in the first week of life, which is what George talked about. I'm sorry, I don't know why my slides keep jumping. I'll keep going back. So the earlier you do ligation, the higher the risk. And if you go towards 30 days, as you can see, the color on this graph kind of changes. It goes to less than 10% of risk later on. So this is an important consideration, and this is one of the caveats when you're looking at all these new studies that are coming describing post-procedural instability after percutaneous closure, is because when you're looking at risk, you have to also assess that based in the context of the baseline risk. So for example, if you describe PLCS in babies who are all 1.5, 2 kilos, and whose cath closure was done at 30, 40, 50, 60 days, that's not really surprising, right? It doesn't really tell you much about the risk related to the procedure because the baseline risk for developing the condition is actually really low in that sort of population. So to assess the real risk of post-ligation or post-closure instability after cath closure, you have to look at a population that is at the same high baseline risk. So the babies who are less than 1 kilo and in who cath closure is done very early in life, as early as the first week, second week, third week of life. So those babies are the ones who have more myocardial immaturity and who have a higher likelihood of developing LV dysfunction. In terms of echo predictors, it's exactly what George said. What we found in the original surgical ligation studies was that the left ventricular output at 1 hour correlated with the left ventricular output at 8 hours, and that was associated with a low systolic arterial pressure and the need for inotropic agents post-closure. And this is what provided the groundwork for the use of early prophylactic Miranone in babies who have a low LVO after PDA ligation. So this was one of the EPOC studies that showed that the incidence of PLCS went from 44% to 11% after the institution of a protocol that used targeted Miranone prophylaxis in babies whose left ventricular output was less than 200 after 1 hour of PDA closure. And since Miranone has both vasodilator, inotropic, and lusitropic properties, it is a very biologically appealing agent for this disease that is characterized by increased afterload, impaired LV performance, and diastolic dysfunction. What you should notice, though, is that although the incidence of specifically cardiovascular instability went down a lot, even in a Miranone targeted prophylaxis approach in this study, there was still a residual 25% of these babies who continued to manifest with respiratory instability. So the next group looked at the same targeted Miranone prophylaxis treated population and found a signal basically suggesting that an isovolumic relaxation time, which is a marker of LV diastolic function, predicted the development of either oxygenation or ventilation failure, even in patients who were treated with Miranone. So as you know, talking a little bit more about diastolic function, with the opening of the mitral valve is dependent on the pressure gradient between the left atrium and the left ventricle, such that when the left atrial pressure supersedes the LV pressure at a time when the LV is still relaxing and it's empty, that's when the mitral valve opens. So there you go, a little bit of red blood cells coming in, mitral valve opens. In the meantime, the left atrium is being continuously filled by the pulmonary veins. If you have a diastolic dysfunction, the LV pressure remains relatively high for a longer period of time, because even though the contraction has ended, the heart is still quite stiff. And therefore, it takes a longer time until the left atrial pressure is big enough to open the mitral valve. And that's why the IVRT prolongs. So we looked at this a little bit further with a study looking at ventricular arterial coupling in babies who were less than 2 kilos, who underwent percutaneous closure, and who also, despite a Miranone prophylaxis approach, which we extrapolated from the surgical patients, also had an incidence of almost 50% of oxygenation impairment. When we looked at the 1 hour after closure echo, the babies who developed instability had higher arterial elastance, a trend towards a higher end systolic elastance, and lower ventricular arterial coupling. And the way that this relates to diastolic function is in the sense that end systolic elastance is a measure that reflects both the active and the passive muscle properties. So different slopes of end systolic elastance have a different impact on how the changes in loading conditions will affect stroke volume, stroke work, and blood pressure. This is a whole new lecture. I'm not going to go into a lot of details, but I did want to put a basic example here with a pressure volume loop that you all should have learned in your physiology lectures. And what you can see is the black line showing 2 different slopes. So there's 2 different trends of end systolic elastance with the same afterload and the same preload for both examples. And you can see that the pressure loop modifies as you change the afterload. So the blood pressure increases, the stroke volume increases, and the stroke work increases. But what's different is that for the same degree of change in afterload, the stiffer system that has a higher end systolic elastance, which is the example on the right, that baby has a larger change in blood pressure with proportionally less change in stroke volume, but a big change in stroke work, which is the shaded area of the loop that is in gray. And what that means, in other words, is that the stiffer system requires higher myocardial oxygen demand to achieve the same amount of net volume or of transfer of blood. When we looked at a slightly bigger cohort with a similar incidence of respiratory deterioration, we found that patients who developed instability had lower early diastolic strain rates after closure, which means that now we have 3 different studies that suggest a trend towards some diastolic function markers, which we will probably need to elucidate in bigger studies, preferentially on babies who are not treated with Miranone, because all of these studies are in treated populations. Any questions about that before I move on to hypertension? Oh, okay. So Another important aspect when we're talking about all of these phenomena of hypertension and diastolic function and the risk of respiratory deterioration, it's the cardiac lung origin, relates to the risk of systemic hypertension after closure. And there's not a lot of literature about this, but I think everyone who's taken care of enough babies going for PDA closure, you can see that the blood pressure tends to go up, and there may be even a trend for babies developing hypertension later on. And of course, we know that the babies who are hypertensive will have more diastolic impairment and therefore will have a higher likelihood of developing respiratory instability. And one of the things that we can speculate is that in the immature kidneys who are chronically underperfused, there may be an upregulation of the renin, angiotensin, aldosterone system in order to maintain perfusion pressure. And when all of a sudden you have an improvement in postductal perfusion by eliminating the ductal shunt, it may take some time for these receptors to readapt. And some of these babies may be predisposed to developing secondary systemic hypertension. So what do we do here when the babies come back from cath lab from a more practical standpoint? One of the ones that we talked about, looking at the new lung compliance. You can see here another example of a baby that went for cath closure and how the compliance changes can be quite dramatic. And therefore try to wean the mean area pressure if you get into a place where the lungs look hyperexpanded so that you don't end up in other types of problems. Babies who get hypotensive because the heart is kind of being squished. Here we do have the ability of doing an echo post-closure, 1 hour post-closure, which guides our choice of using Miranone prophylaxis. We do a routine X-ray 6 to 12 hours after the procedure to try to identify those early changes radiographically so that we can tweak a little bit on the ventilator for any potential respiratory deterioration. And last, but obviously not least, very close monitoring of blood pressure. Not only from a hypotension standpoint, which is quite rare actually in our cohort of babies, but more commonly from a hypertension standpoint, especially as the baby's sedation starts to wear off, they start waking up and their blood pressure can be quite elevated and can predispose them to more respiratory instability. Looks like I had a couple more things. We also look at in-organ perfusion routinely. We tend to do gas, lactic acids every 6 to 8 hours. Obviously keep a close eye on their urinary output and look at the blood pressure, especially even if after Miranone you're still having high diastolics, that may be a trigger for us to give a little bit more Miranone or to even start in the ones who didn't qualify initially. You also may have seen this slide before. I just will leave it here as a summary of management strategies for the different presentations after PDA closure. But like I said, early or diastolic hypotension is usually not part of the PLCS spectrum. You can consider giving volume if there's a suspicion that this baby may have fallen into no longer the flat part of the Frank-Starling curve. Assess to make sure that there are no other vasodilators or other drug interactions. Make sure that there's no lung overexpansion and no other lung complications like pneumo or hemothorax, and always consider adrenal insufficiency, especially if you are in centers who don't routinely give steroids before the procedure. And in the cases where this is persistent, refractory, or very severe, then of course you may need to discontinue or reduce the Miranone if the baby is on that. For the babies who develop cardiovascular instability with systolic hypotension or signs of low cardiac output, if you have an echo to assess heart function, that would be ideal. If it's in the middle of the night and you just want to treat it empirically, the drugs of choice, you want to go with inotropes, so either dobutamine or low dose epi. Always make sure you check the device. One potential, particularly after cath closure, although I have never seen it, is that the device could migrate, and it could migrate specifically into the aorta, which could cause an upper and a lower limb blood pressure discrepancy, like a coarctation type of physiology. And although the chest X-ray is not going to be perfect to assess the device, you may pick up on that. If it's persistent, you may need to do an echo to make sure that the device hasn't moved. And importantly, if you do have predominantly systolic hypotension, that's not an indication to stop Miranone, because Miranone is actually helping those babies who have a higher afterload state and who are contributing for their systolic hypotension and LV failure. In the majority of the babies, are the second part. So for babies who have systemic hypertension, particularly if they come with respiratory symptoms, if they are on steroids, if they got stress dose steroids, try to wean those and not do iatrogenic things that may make them worse. You can use sedation if you need. If you started a low dose Miranone and the baby's still hypertensive, you can go up on the Miranone. And if they have respiratory symptoms, of course, look at an X-ray, adjust your vent settings, go up on your mean airway pressure if you need to. If there's a sudden hypoxemia, again, device placement, the device could migrate to the other side into the pulmonary circulation. You may or may not pick up if it migrated a lot. You may see that the device has flown into the LPA or the RPA, or you may need an echo for that. If it's just the typical course with respiratory decompensation because of high LV pressures, you can consider diuretics and just adjusting the Miranone like we talked about. In these settings, acute pulmonary hypertension and RV failure are actually quite uncommon because that's not the usual physiology. And if there was a predisposition for that, particularly if the baby was older and already had some high PVR, the first echo usually picks up on that, but it's very rare for babies to need inhaled nitric oxide as the reason for their respiratory decompensation. And I guess, well, I already talked about acute isolated hypoxia could be from device embolization. So I'm going to finish off here. This is all that I had for slides, and I think we can open up for questions. This is my team. Thanks, team.
Thanks, Adrianne. That's an amazing talk. Thank you very, very much. I'm certain there's going to be questions. I do want to, for our audience, just one small pointer that we have the panelists who are our trainees in neonatal hemodynamics and TNE, and there are people joining us as seminar participants who we can't view. I'd invite everyone to ask questions. For our seminar participants who are not on the panel, please do put your questions in the Q&A and I'll be moderating those. For our trainees who are here on the panel, I encourage you to just raise your hand and I'll certainly call on you in turn. So please, again, thanks for a really fantastic talk. I think bringing together some really core principles of hemodynamics, the effects of preload, as well as impact of afterload on systolic and diastolic function. So I'm certain there'll be questions and we'll get to the first one. There's one from Dr. Hakak. And his question is, would you consider AC-PC volume guarantee the better option mode of ventilation after PDA closure to prevent lung overinflation? I'm guessing in comparison to something like high frequency.
That's a good question. I think that's very dependent on which center you are and what type of practices you use. Here at Iowa, our primary mode of ventilation for tiny babies is the high frequency jet ventilator. And as long as you know that their compliance is changing and that you're dropping their PEEP, their mean airway pressure, and adjusting their ventilator settings, the jet can be just as fine. But I have seen in other places, if you are on the oscillator and you have a tendency to keep the same high mean airway pressure that the baby needed pre-op, that they may be more likely to run into issues. So I don't think it's about the mode necessarily itself, but just being upfront about knowing that the compliance will be different and that you probably will have to wean the ventilator after the surgery.
Thank you. There's this next question. From Dr. Benitez, in which case do you recommend the use of Miranone before the PDA surgery? Perhaps they meant after. In which case do you recommend use of Miranone after PDA surgery?
So after PDA surgery, we are doing the same that we extrapolated from the surgical ligation studies. So we do an echo 1 hour after closure for all of our babies. And the ones who have a left ventricular output of less than 200, particularly if they are babies who are at the higher risk. So babies who are less than 1 kilo or who are less than 1 month of age and who may have other signs on their echo of either systolic or most commonly diastolic dysfunction. So long IVRT, bigger E to E primes, very small E in comparison to the mitral EA, and things like that, then we may have a higher threshold for starting Miranone on those babies. Having said that, using that strategy here at the University of Iowa, 80% of our babies end up qualifying for Miranone. So I don't know anymore if 200 is the correct threshold. So we end up being that if they're less than 170, pretty much we always put them on because we're afraid until we have more data of what the correct threshold is. If they're kind of a borderline baby, 180, 190, and they don't really have a lot of risk factors, sometimes we hold off and we just monitor their parameters with blood pressure and so on and so forth carefully before actually indicating prophylaxis.
Great, thank you. Next question from Dr. Suresham. PDA ligations are less in the last decades. What are the indications for PDA device closure?
So like I said, there's a lot of debate on when and who you should close. Here we consider closure for babies who continue to have a shunt that is hemodynamically significant. We use a PDA score to adjudicate significance of the PDA, and those that we consider to have moderate or high volume shunt that have either failed repeated courses of medical therapy or who have had a contraindication for any additional therapies are the ones that we recommend definitive closure. We tend to do cath closure as our primary mode these days, and we only end up doing surgical closure for the really small babies who we don't think that would be safe to mobilize to the cath lab. There's not really a clear cutoff. The FDA cutoff for a Piccolo device is 700 grams, but we know that there's a lot of centers who do this procedure in babies as small as half a kilo. We've done it in 600 gram type of babies. But if they're much smaller than that, then we still go for traditional surgical ligation that we have the ability to do at the bedside.
Thank you. And next question is from Dr. Rao. Are there any studies looking at cerebral oxygenation post-PDA catheter device closure or ligation that you know of?
From catheter closure, I don't know of any studies that have looked at NIRS. There may be something for surgical ligation, but I actually can't remember from the top of my head. Do you remember any, Danny? Can you help me out?
There are a couple of very small prospective studies that have looked at that. I mean, ultimately, the question is that data going to impact your desire to do the procedure or not? It's very unlikely. But there have been studies showing that there is an impact. It does drop as well. And so both with NIRS and with amplitude integrated EEG, that there is a broadening of the baseline. The challenge is whether it's related to the hemodynamic derangement or also some of the medications that are given during the procedure, like the anesthetic medications. Okay, there's another question from Dr. Kariuki. In which clinical circumstances would PDA closure be done as early as the first 3 weeks without attempt and reattempt of medical management? And is post-ligation syndrome incidence falling? So I guess two questions. So first one is, in what circumstances would you do the PDA closure in the first 3 weeks? Second question about the incidence of PLCS, post-closure syndrome.
We have a very, almost not aggressive, but a very early approach to PDA shunt, because we do know that prolonged PDA shunt exposes the vasculature to remodeling, increases in PVR, and potentially worsening the risk for BPD and other morbidities. So we tend to be kind of early in our approach, and we start treating the PDA as early as day of life 1. So if you think of our traditional medications that we use, we go with Tylenol for the first week of life. That's 7 days at the most. And then the next course of therapy that we do here at the University of Iowa is indomethacin. So those are 2 courses back to back that you can try. By then you're at the end of the 2nd week. If the PDA is still significant and hasn't closed, then we pursue with referral for definitive closure. So usually by the 2nd week of life, could be the early as it goes. The majority of the babies, though, are not babies who never respond. The majority of our babies who go for a definitive closure have a relapsing, remitting type of course. So they do respond partially. The PDA becomes smaller, restrictive, and then something happens. The baby gets septic or something different occurs and the PDA remanifests. You treat it again, you get some response, you treat it again. And that's what the majority of our babies are going for closure between the 3rd and the 4th week of life. But if you have a baby who is just unresponsive at all to any sort of medical therapy, by the 2nd week of life, we may be already referring those type of kids. And what was the second question?
About the incidence of post-PDA closure syndrome.
It's hard to say because there's very few studies looking at the populations that are at higher risk for post-closure instability. Like I said, it depends on which population you're actually looking. So you have to be assessing for both cardiovascular and respiratory instability in babies who are less than 1 kilo and who have their closure done early enough that they would be at higher risk. There's a feeling, but it's not really obvious at the moment that percutaneous closure may be coming because of perhaps less inflammation, less lung retraction, and it may come with less instability. Like I said, here at Iowa, our population is treated. It is a very high risk population, and despite those babies being treated with prophylaxis at a high rate, we still have 50% of our babies who do have some respiratory instability. And that's not to say that we shouldn't be closing these ducts. We absolutely should, and we are very pro closing the PDA if it's something that's causing a hemodynamic significance to the patient. But just being mindful that these complications do happen and that there are probably things that we can do to avoid the babies from getting too sick in that first 24, 48 hours after the procedure.
Excellent, thank you. We have a question from one of our panelists, Dr. Sacker.
Thank you, Dr. Dani, and thank you, Adrianne. So actually 2 questions regarding the echo post-ligation. So the first one at 1 hour, then how you kind of tailor or you organize your echoes? Is it clinical based or you have like strict criteria when to repeat the echo?
We only do 1 hour after. We would only repeat an echo if a baby is very unwell and does not respond to the usual courses of therapy. Like I said, we only have about 5 babies in all of the 60 ones that we've closed who had some sort of systolic hypotension or need for inotropes after percutaneous closure. And we've treated those babies empirically with low dose epinephrine or the butamine, and they've resolved and we weaned them off clinically as well. Maybe 1 or 2 babies, we repeated the echo just to confirm that that was the diagnosis, and it was. So we don't routinely do echoes beyond that 1 hour, but if it was a course that is not following the usual trajectory or the baby's not responding to the management, then that's when we would repeat it.
Thank you. And the second question actually regarding some practice I noticed or I saw recently, like when those ducts are left for a long time and the baby reached to the 3-4 months age and now still like severe BPD and chronically ventilated, and the discussion started about tracheostomy. Then some people, they will kind of like insist, let's close the BDA before going for tracheostomy. Let's take the BDA out of the picture. So is that something really important or really of any value at this age?
I think it depends. I'm going to stay over the fence for that question because it depends. It depends on what your markers of significance are. It depends if your PDA has already caused an impact on the pulmonary vasculature and you have a secondary problem with high PVR and pulmonary hypertension. And if that is the case, at that point, it probably wouldn't even be safe to close the PDA, because if you have high pulmonary pressures and you suddenly close the duct, you may put the RV into trouble, which is a different type of physiology. So I think it depends. If it's still a very large shunt with very obvious left to right, left heart volume loading, it may be of benefit. But be mindful that once you get to 3-4 months of life and your BPD is already established, the impact on lung function may not be as significant as if you had done this much sooner in the baby's life.
Thank you. Thanks, Adrianne. You're doing such a great job with all these questions. I did want to make one, I think, small point there. But let me just get to the questions and I'll finish off with my thoughts there. There was a question from Dr. Meka Bravo from Madrid. Her question was, do you have any experience using non-invasive continuous cardiac output monitoring to assess the onset of PLCS?
We don't use it routinely. We have this in a research setting. I know that Danny did a study with non-invasive cardiac output monitoring, and it did correlate with the LVO and the incidence of hypotension and need for inotropes, but we don't routinely use it in our practice. We have non-cardiac output monitoring for research only at the moment.
Great, thank you. The next question is, are percutaneous complications the same as complications for ligation for PDA, but less severe? And do you recommend the same guideline for units without percutaneous closure? So the two questions are, talk about the complications of ligation versus cath closure, and then do your recommendations for management pertain to either ligation and device closure?
So there are complications that are going to be specific to each procedure. There are surgical complications, like we know hemothorax, pneumothorax, laryngeal nerve paralysis, rupture of the duct, and surgical complications itself. There are percutaneous complications because of the procedure, like cardiac tamponade, injury to the tricuspid valve, obstruction of the LPA or of the descending aorta, and things like that. And then there's a common ground, which is the whole spectrum of post-closure cardiorespiratory instability, that the physiology is very similar for both, because we're talking about removing the PDA and removing the shunt, and the changes in preload and afterload are going to be the same, irrespective of how you are definitively closing the duct. Like I said, it's hard to say. We here at Iowa, we have extrapolated the same type of protocol with Miranone prophylaxis and preemptively looking at blood pressure and respiratory deterioration after procedures, and we use it interchangeably, whether it's definitive closure from a surgical or from a percutaneous standpoint. So I do think that that's a reasonable thing, because the physiology is expected to be the same. However, having said that, there is the caveat that we don't know what the right thresholds for LVO 1 hour post to choose Miranone prophylaxis was done in surgically ligated babies, not in percutaneous ligated babies. So we don't know if that's the right thing to do or not. It would probably be good to have a center that doesn't use Miranone prophylaxis to replicate the same studies that were done for surgery, but we're not going to do this here at Iowa. I'm just going to tell you that our group is not going to be comfortable not putting these patients on Miranone anymore. So for those of you who don't use it, there you go. There is a project for you to do.
It's a great point. I think there is reticence to use Miranone, and there was one neonatologist, one commentator who mentioned that Miranone is a drug looking for an indication. I think people who think about hemodynamics often would find that a bit too much of a simplification, I think, because Miranone fits as a treatment or even prophylaxis. It fits the physiology here actually perfectly. You can't ask for a better drug, but I recognize that the enthusiasts for evidence-based medicine, there isn't the same, I think, threshold to universally endorse it. That said, there are trials in pediatric cardiac surgery, that Miranone does decrease low cardiac output syndrome and death in that population. So there is fairly high-level evidence, just not specifically for PDA and PREMS. Okay, great questions. The next question is, when do you start prophylactic Miranone? Is it during surgery?
No, we started after that 1 hour echo. So we start the echo instead of going through our normal sequence of images. The first things that we take is a 4-chamber and an LVO. And if the baby has an LVO less than 200 and is a high-risk baby, we already tell the nurses and the clinical team to start ordering Miranone, to have it at the bedside and start at that point, but not during surgery. No, it's a post-operative type of thing. We actually, most of our babies already have Miranone in line, because we already know that the incidence of having a left ventricular output less than 200 is very high in our institution, that we just order it, we have it at the bedside, and if it's indicated, we simply start it at that time.
That's interesting. I remember, we have some challenges sometimes getting it going. Sometimes it takes 3 or 4 hours. So in general, you can speak generally, what's your time to the Miranone hitting the baby post-operatively?
We do the echo exactly at 1 hour. At 1 hour and 10 minutes, if we indicate it, it's already started.
Okay. That's a nice structural way to make sure it hits the baby. Dr. Jacob, you have a question.
Hey, Adrian, how often you have to stop Miranone for diastolic hypotension or any hypertension per se?
So that's a great question. We had a couple of babies right at the beginning when we started with the protocol that we had to start, probably 3 or 4 babies that we had to drop the dose. But we found that those babies who had early diastolic hypotension right after starting Miranone were babies who were on a vecuronium drip. So that was kind of a leftover from the surgical protocol. So the babies here at Iowa, when they were surgically ligated, they were put on a vecuronium drip to stay muscle relaxed for the first 24 hours. That just got extrapolated and we didn't notice. And all of those babies who developed diastolic hypotension profoundly after Miranone got started had a combination of both drugs. So once we've eliminated the vecuronium drip, that problem just went away and we haven't had any issues with that. There may be some babies that we've dropped the dose from 0.33 to 0.25, really immature babies, while they still have some sedatives on board because they still get vecuronium boluses during the procedure. But that's actually quite rare now that we've noticed that association.
Great question. Thanks for that answer. Next question is your team following up these infants who have post-surgery syndrome with evaluation for neurodevelopmental outcomes, and which group did better, the ones with or without post-closure syndrome?
We don't have any studies going at the moment. We would have to do that in the future. Percutaneous closure just started about 2 or 3 years ago in this institution, so we wouldn't have enough babies to look at that incidence quite yet. And like I said, our post-ligation or post-closure respiratory instability is primarily a respiratory thing, not really a cardiovascular thing. We don't have a lot of babies who have low cardiac output state. So I'm not sure if there would be much of a significant impact, but that would be a good project for someone to do in the long run when we have enough babies.
Sounds good. I would say add just for the post-ligation babies, there's a mixed answer to that question. I know Meka Bravo in Madrid, she had a cohort where the PLCS babies had worse neurodevelopment, though others, the Toronto cohort, we didn't publish it, but the PLCS was not associated with neurodevelopmental outcome. Okay, next question from Dr. Colthorpe.
Thanks. Thinking about sort of the neurodevelopmental side, and when we were talking about the sort of use of vecuronium, I know in one of the papers it was talking about sort of quite significant drops in cerebral saturations during induction and anesthesia. I wondered if you guys did anything different, or if you had any sort of specific protocol that was different to a usual operation in this sort of situation.
So no, here at the university, like I said, most of our babies, these micro preemies are all on the high frequency jet ventilator. They do need to be muscle relaxed for the procedure to be more safe and easy to perform. So what we do here is that we sedate and muscle relax the patients in the unit, because we know that once you take their respiratory drive, their compliance and their CO2 clearance can be quite different from when they were still spontaneously breathing on the vent. And then we do a gas in the unit before we mobilize them, so that if we need to adjust their ventilator while they are muscle relaxed, then we can do that. But we still use morphine, Ativan, and a vecuronium bolus. And then we start a morphine infusion to keep them sedated until they go, and then they come back. If they start moving in the cath lab, then the anesthesia team may or may not rebolus them. And that's kind of dependent on the patient and how long it takes for them to prep.
Great. I think we'll have time for just the last 2 questions here. If systolic hypotension after closure did not respond to the usual dose of Miranone, what is your next step? To increase the dose or add a new medication?
If we end up in a place where we do have obvious systolic hypotension, we would start an inotrope. So either the butamine or low dose epinephrine. And when I say low dose, I say 0.03, 0.05 type of thing. And we keep the Miranone going if the hypotension is predominantly systolic.
Great. And last question is, do you give a loading dose of Miranone? Maybe speak also to any data that you know about the pharmacokinetics of Miranone in this population.
We typically don't use loading doses of Miranone in any populations, including this one. We just do an infusion. We do have weight-specific thresholds that are not really based on science, just out of fear. In the really immature babies, the preterms were less than 1 kilo, because their renal impairment may be different, specifically if they've been exposed to a chronic shunt and may have some degree of acute kidney injury on the background. We tend to start at a lower dose of 0.2, 0.25, but that's just fear-based. It's not science-based. For the more mature or bigger babies, we start at the usual 0.33, but we don't use a loading dose, no. We do give a normal saline bolus of 10 cc's per kilo during the first hour of the infusion, and that's to try to prevent a little bit of that initial vasodilator impact and any potential preload problems that may have been under-recognized.
Great, thank you. Okay, I think we'll draw things to a close. Fantastic presentation. Thank you for answering all of these, probably 20, 25 questions. So thank you very much, Dr. Bischoff. And I'd like to thank all our panelists for their participation and great questions. Our seminar attendees, also fantastic questions. And on behalf of my co-chair, Dr. Danielle Rios, as well as our admin executive, Ms. Laura Thomas, I want to thank everyone again for joining us today. And again, thank Dr. Bischoff for a great talk today.
Thanks for inviting me, and thanks for reading the papers and answering the questions.
Thank you. Okay, everyone, we'll see you next month.